This is a 52-year-old right-hand dominant male who injured his right shoulder following a bicycle accident. X-rays, including an AP and cephalic tilt view of the right clavicle, demonstrate a comminuted displaced mid-shaft clavicle fracture with more than 100% displacement and shortening. According to the system of Robinson et al., this fracture is classified as a type 2B1. We prefer to position the patient in the beach chair position. The image intensifier is brought in from the opposite side of the patient to be out of the operative field. An AP and cephalic tilt view are easily obtained in this position. The entire forequarter and arm are prepped and draped free. The clavicle and associated landmarks are palpated. The incision line follows the length of the clavicle and is centered over the fracture site. The skin is incised down to the platysma muscle. The supraclavicular nerves may be preserved if identified. The platysma is divided, and the interval fascia between the pectoralis and trapezius is identified. This interval is divided, and the soft tissue is elevated off the superior aspect of the clavicle. It is important to keep these flaps thick for later closure. A blunt elevator is used to elevate the soft tissue superiorly. Care must be taken to maintain soft tissue attachment inferiorly. The medial and lateral fragments are identified, and a provisional reduction is obtained with the use of clamps and arm traction. Reduction is confirmed radiographically. A K-wire may be placed to hold the reduction and allow for clamp removal and subsequent superior plate placement. This system, as most, has both superior and antero-inferior plates available for use in these fractures. A superior plate with the appropriate contour is chosen and positioned with at least 3 screw holes on either side of the fracture. Final reduction adjustments can be made with the plate in place prior to screw placement. Plate position is confirmed radiographically prior to screw placement. If a simple fracture pattern is present, one screw may be placed on one side of the fracture and dynamic compression applied through the plate with a screw on the other side of the fracture. If the fracture is comminuted, as in this case, a bridge plating construct may be applied. Care must be taken to control drill depth past the second cortex to avoid damage to the subclavian vessels and the lung. Drill paths are measured and screws of appropriate lengths are placed in standard fashion. Locking screws are used in this case due to the comminution present in order to improve fixation construct strength. At least 3 bicortical screws should be placed on either side of the fracture, especially if no lag screw is utilized in the fixation. Following completion of fixation, final radiographs confirm final implant position and screw lengths. The wound is copiously irrigated. Grafting may be performed in the case of bone loss. In this case, demineralized bone matrix is used to fill comminuted gaps. The deep fascia is repaired with interrupted vicral sutures. The skin is repaired in 2 layers with a subcuticular repair. Immediately postoperative, the arm is placed in a sling and immobilized for 1 week. The patient is begun on active assisted range of motion with forward elevation limited to 90 degrees. Isometric strengthening of the shoulder, elbow, and wrist are begun. At 12 weeks, full range of motion of the shoulder is allowed and active strengthening is begun. At 4 months, the wound is healed. The patient has full symmetric range of shoulder motion. Internal and external rotation about the shoulder are full. Radiographs at this time interval show progression towards full healing.